Okay, I want to talk about this really interesting case. It was a 50-something-year-old male who presented to the emergency department with forearm pain and deformity, status post-assault. His vital signs were stable and he had no other apparent injuries. Examination of his left upper extremity identified an obvious swelling and deformity of the forearm with inability to range at either the elbow or the wrist. His median ulnar and radial nerves were intact. His radial pulse was 2+, and his compartments were soft. X-rays were obtained, which identified a Monteggia fracture dislocation. And what that means is there's two lesions that characterize this. One is a midshaft ulna or diaphyseal ulnar fracture, typically on the proximal side, as well as a radial head dislocation. And you can see with the yellow arrows, the radiocapitellar joint is not articulating. So a Monteggia fracture is characterized by midshaft or proximal ulnar fracture with a radial head dislocation, named after an Italian surgeon who first described it in 1814. It's relatively rare, representing only 1 to 5% of all forearm fractures. It can happen from a fall from height, sports, motor vehicle crash, or low energy trauma in the elderly, and also a direct blow to the forearm with the elbow and extension and arm pronated. So here's an illustration of what this fracture injury could look like. You can see them falling on an outstretched hand. The wrist is pronated and extended, and the forearm is also extended. And you see this vector up the ulna with an ulnar fracture, leading to a radial head dislocation. Differential diagnosis includes elbow dislocation, proximal radius fracture, midshaft ulnar fracture, which is sometimes called a nightstick fracture, Monteggia fracture, Galeazzi fracture, Essex-Lopresti, distal radius, and then a radius ulnar fracture or a both bone fracture. That says bone, that's a typo. On exam or by history, patients endure some type of trauma and they complain of pain and swelling. There's usually an obvious deformity with limited range of motion. And the most important things on initial evaluation is to examine for any open injuries to suggest an open fracture or a traumatic arthrotomy, and then a thorough neurovascular exam looking at the nerves and arteries of the forearm. Radiographs are typically sufficient to make the diagnosis. On the lateral elbow, you can see radiocapitellar line will be compromised. That sometimes is subtle. CT is useful for operative planning and MRI for soft tissue evaluation. These are almost universally surgical and require open reduction and internal fixation. Prognosis is typically better in kids than adults. There is a phenomenon called the neglected Monteggia syndrome, in which a missed or mismanaged Monteggia fracture leads to chronic elbow deformities and arthritis. And complications include lesions to the posterior interosseous nerve, the TFCC, and acute compartment syndrome. So in the case of our patient, the orthopedic surgeons attempted a closed reduction in the ED, and on the right you can see this picture where the ulnar fracture is here, the radial head is here, but it is not articulating with the capitellum, so closed reduction was not successful, and so he was admitted to the hospital for an open reduction and internal fixation the next day, and discharged, I think, later that afternoon. And last time he was seen in clinic, he was doing well. So 3 key points about Monteggia fractures is that they're defined as an ulnar diaphyseal fracture combined with radial head dislocation, so better called fracture dislocation. Management is almost universally surgical, except in some kids with a stable radiocapitellar joint. And then neglected Monteggia fracture is an unfortunate complication of either misdiagnosis or mismanagement in which patients develop some serious elbow pathology.